I'm Laura with Denver Mom Collective, and today we're chatting with Dr. Presley Swann. He's a board certified and fellowship trained orthopedic surgeon with HCA HealthONE. Thanks so much for being here with us.
Yeah, thanks for having me.
We're going to chat a little bit about hip dysplasia and why more young women are being diagnosed with hip problems and what moms should know about advocating for themselves when pain doesn't feel normal. Um, let's just jump right in on why do you think hip dysplasia and hip pain are often missed or dismissed in young women and moms?
Really, it's a lack of education. I think we're getting better as a medical community of identifying it, but still, I mean, there's zero training in med school in this. So, if you go into OB-GYN, you go into family practice, um, unless the imaging shows a clear diagnosis that then gets reported back to the primary care or OB-GYN, then they say, I don't know what's hurting. And unfortunately, still in 2026, I see patients that they've done studies on the average time it takes from the moment you start complaining of something's wrong with my hip, which would for most of the part of the time be groin pain, like you feel like you have a groin pull that just never goes away. You feel like you overworked it too much. 20% of the time it can be the side of the hip, and 10% it can be behind. But they've done studies of when you actually start complaining, how long it actually takes to get to someone like me, and it takes 2 years of advocating for yourself, unfortunately. And so uh, it's just one of those things that's just not commonly studied. Even if you see an orthopedic surgeon, particularly if you probably see somebody older than me, they'll say, I don't know what's going on. Just
Mm-hmm.
here's some Tylenol and here's some therapy. And even in a city like Denver and Kansas City, where you're from, I see patients from there that get frustrated and come to see me for opinion because they just get bounced around. But I had partners when I was in private practice that just would inject, 14-year-olds hip with steroids, which isn't the best thing. And they wouldn't know what they were treating. They're just like, well, we're here to help you, but don't know what we're treating. So it's, I would say labral tears, which, the dysplasia is the underlying reason usually in females, but, the top two reasons why people get hip replacements in the United States is there's a structural reason. It's not just like your hip wears out. So number one would be impingement, and then number two is hip dysplasia. And so if you can identify and fix those underlying causes, usually you can delay or alleviate the need for a hip replacement in the future. But really, it's if you're having symptoms, and then the correlation, all that usually in MRI is a labral tear. And for me, the labrum is more of a symptom than the disease. You have to figure out why the labrum has torn in a female or a male patient.
Okay. So, hip pain in young women is often brushed off as overuse, sports strains, pregnancy changes, just part of being active. But for some women, that ongoing pain can be a sign of these serious conditions. What would those early warning signs be that can kind of alert us to pay a little more attention?
Yeah, really, it's groin pain, feeling like you pulled a muscle that's just not going away. It could be lateral or posterior pain, as I said before, but you can also get clicking, so particularly painful clicking. And I have a labral tear in my hip. I know exactly when it happened in my life, and so it doesn't bother me that often. But when it shifts, it hurts like you're getting stabbed, like something's wrong in there, and then it aches for a few days to a week, and then it just kind of goes away. Those are the typical symptoms of a labral tear. Like it's not all the time, as it becomes more all the time, and that's how I counsel patients on when to have surgery. Is how I treating myself or my family is, um, if my labrum flips in and out every couple of weeks or every month, then I'm probably doing something. But if it only happens once or twice a year, I'm probably sitting on it until it gets worse. But it's getting worse or tearing more the more those episodes occur. And interestingly, you brought up about, after pregnancy, that it's just, these things happen. We actually have a pretty good understanding that the hormonal influences that women go through in a pregnancy change the hip structure. So if your hip's sitting on the edge of being unstable and you've never had symptoms from dysplasia, I see women in their third trimester and peripartum all the time that they're like, this is worse than the pregnancy pain. And it's because all the ligaments get lax to be able to have to bear a child. So your pelvis actually widens to widen the birth canal. Everything gets a little looser during that time, and when that happens during that time, an underlying problem may start to show itself pretty badly, and then your hands are kind of tied until the baby's safe enough to then look at it with imaging, etc. But there's all sorts of reasons. It can be activity level. Women, whether you're in high school or college and doing, cheerleader, gymnastics type activity. My brother's got 3 daughters that they're doing high level gymnastics, and I as a professional, I'm like, yeah, I don't know if this is the best idea. And overuse injury is real. And we were just having this conversation before we jumped on this interview about, how intensive and kind of crazy these childhood sports have gotten in the United States, and it's accurate. I mean, I coach my kids. I coach baseball and football, and parents have their kids in 5 days a week, 360 days a year athletic training. That wasn't like that when I went through, and I don't think it was like that when you went through. And it's gotten so intensive that some of these issues are like, yeah, I mean, kids' bodies aren't made to do this all the time because they are growing. And so, hip dysplasia, labral tears, FAI, it could be an issue in that, kids don't typically tear tendons. That's when we get older. But what they do is their tendons attached to the bones, their growth plates. And if they're constantly getting pulled on, and with baseball, instead of getting like the Tommy Johns or tear here, what they do is pull the bone off, or at least it elongates because the body's trying to accommodate for that stress. The same things happen in the hip. You can get hamstring pull offs, rectus tendon pull offs. Or if they don't pull off, they can show up in their 20s or 30s as now a chronic issue because the bone has strengthened up the hip, but now it's not where it should be. And so all of these things, can be overuse issues, but there's so many different reasons why it can happen.
So in Denver, are you seeing a lot of dancers, gymnasts, and cheerleaders or female athletes in general at a higher risk for these hip problems?
Yeah, so I mean, I see all comers, males and females. If we're talking about the female population, yeah, I say it's the blessing and the curse, and that you're not usually just born with flexibility, and you can coax hips into being less covered, like hockey players, for example. But I've treated Dallas Cowboy cheerleaders, Houston Texan cheerleaders, and the reason they're able to take their leg and put it straight up is because most of them have hip dysplasia. They have an undercovered socket, and it's really the freaks of nature that don't get injuries from it that are very rare. So most of the dancers burn out from their hips. And just like an NFL running back, that's a freak of nature, that they've got a very bow-legged knee that makes them athletic, but then they may blow their ACL at some point. And so it's the blessing and the curse. It's the reason for the hyperflexibility that sets you apart, but it also means it's potentially a ticking time bomb of a problem that's when your career ends.
We've been sharing Lily's story that you treated, and we'll have a blog post on the website as well. So, with Lily, why did you recommend a stage approach with that 2 surgeries instead of one?
Well, so her case was extremely complicated in that I remember her really well, seeing her the first visit. And usually, patients are scared of needing potential surgery, potentially major surgery. Um, and they know when they see me something's wrong, and that's why they're in a surgeon's office. And unfortunately, I didn't do a good enough job, I guess, communicating my confidence in how good I am in my field. because I don't do a good job, nor do I necessarily sell myself to a patient. And whereas other surgeons can, and say I've treated so and so and so and so, and exude like this must be the place to go. And unfortunately, with her case, she went somewhere else for treatment, and it did not go well. And she actually, was worse than where she even started. And it was an extremely complex problem to fix. And so when she had the first problem, she could have had a isolated labral repair and PAO on the same day and done great. I mean, at least 98% of the time in my hands. Um, and unfortunately, what she had done wasn't done technically perfect, and it caused issues where even sitting down was causing issues. And so, when she came back to see me, like, well, why is this going on? And I'm really sorry for not, going with you the first time. I said, well, I'm here to help you. This is a problem. Um, and to do a revision surgery is very much, akin to having a brand new car that if something goes wrong, you take it to the dealership, and you and I both know that it could be like, well, you fixed it, or it could be like, well, we're in the shop all the time now, and each time it
Hmm.
seems to be worse.
Yeah.
And so that's how, unfortunately, redo or revision works can go, is that you really have one shot to get a hip right, maybe a second. And that's when I see, unfortunately, these redo cases from across the country, that they are not necessarily a slam dunk, or like, I can fix this. And so that's why we broke that up, is because she needed issues inside of her hip to actually fix, that type of damage that wasn't taken care of. And then I had to redo the PAO to fix the dysplasia, but also what was done technically not so good.
So in that case, and I'm sure there's been others, as you mentioned, when someone's had a difficult medical experience in the past, how do you rebuild that trust with them?
Yeah, what a great question. And, my answer is going to be as honest as I try to be with my patients, is I may not be the best at that. We get zero training at how to communicate this type of news. You do in medical school a little bit when, we had a module and like telling someone they had cancer. And the best way to do it is to say, I'm sorry, and I'm here for you, and tell them the facts of the case and to be honest with them. Uh, that's how I approach all of the cases when my patients see me, is that one of the, I guess, critiques that I see online about me is I'm very businesslike or straight to the point. It's how I want to be treated, and so that's how I practice. And that I've had my dad in and out of the healthcare system, and I don't like things sugar glossed over, told everything's going to be all right when it's not. And so I feel like my job is to provide the patient with the information to allow them to make good decisions in their care moving forward. And so that's really the only thing I can do, is say, well, here's where you're at, here's what I know I can do, and here are the statistics of that. And do you want to proceed? And, with me, do you want to proceed at all? And really have that decision where I'm not going to come in and say, oh, this is terrible and I can fix it and you're going to do great. That's not necessarily true. And I don't think that does a patient a good service to paint that picture. Um, and to me, that breeds mistrust if you're not being honest with that patient. So to tell them what is exactly going on is unfortunately a double-edged sword, where it's like, well, this is doom and gloom. I don't have necessarily hope. But to me, saying, I've got an 80 to 90% chance of fixing this is hope. But I also have a 10 to 20% chance of, unfortunately, when I see these redo cases, that don't do better. And that's, the burden I bear to be a surgeon that takes care of this stuff. Is, it's terrible when these patients don't do better, and we're well intentioned to try to fix them. And if I'm a glass half empty type guy, then or gal, you feel like, wow, I've saved 8 or 9 of these. But that's not how good surgeons think. We think about the ones we didn't. So,
Got it.
um,
So, what do you wish more women knew about advocating for themselves when living with chronic hip pain?
um, it's really to get to the bottom of what's going on and asking the right questions, and not, if you were told to get therapy and it should get better and it's not, don't kind of get gobbled up by the system. These things can be pricey, and that, a round of therapy is not cheap. And then doing 3 rounds is definitely not cheap. So if you don't feel like you're getting improvement, then keep pushing. um, and don't let geography be your boundary. And so that's one of the things I've learned in my practice, and that I've, really done a good job of taking care of patients, even if they live in New York or LA, because I've had to figure out how to get those patients taken care of and do all their care post-op, et cetera. Is that, if you look at the geographical region from Houston all the way to Florida, there's nobody doing what I do. And you have somebody in Houston, you have somebody in Florida, but the states in the Gulf South are really don't. And just because you have a surgeon there that does it doesn't mean they're necessarily that good. So um, that goes for across the country. And so I would say do your homework, um, and the homework best being, looking at online reviews, looking at a surgeon's pedigree. That really matters, of where they trained, how long they've been in practice, how many they've done, um, and putting in that investment. But unfortunately, I understand how that engine works too. Google can be paid ads, Google's can be marketing to prop you up, but not necessarily mean that that's um, how to find the right person. Then I would say once you hone in, start asking the nurses and the people that are actually in the ORs with the doctors. If the doctor makes it look easy every time, and people like to work with them, it usually means they're pretty good at what they do. Um, but I would say don't let geography be a boundary. So, and as we were discussing, I see, not a ton, but maybe 5 to 10 patients a year from Kansas City. Um, that say I've had a previous hip scope or two and it's not going well, and I need answers, and you seem to be the closest thing as an answer. I know there's other surgeons that I really trust across the country, one being at St. Louis at WashU, one being in New York, one being at Minnesota. And so it doesn't have to be me, but it should be somebody that's like, I do this all the time at a high level, and don't let, well, it's, this is a flight, or this is a hour long drive, because it's the rest of your life, and it is, your body and your health are priceless.
That's great. Well, thank you so much for sharing more about your specialty and that there are solutions there for ongoing hip pain for women and young girls. If you or someone you love has been living with ongoing hip pain, you don't have to keep pushing through it alone. Learn more about hip preservation care, treatment options, and specialized orthopedic services through the HCA HealthONE Hip Preservation Program by visiting hcahealthone.com. Thanks so much, Dr. Swann, for joining us.
Yeah, thanks for your time.